Hi, I'm Andrew Watson. I'm an associate professor at the David Geffen UCLA School of Medicine in the Division of Cardiology. I'm going to be giving a lecture on cardiomyopathy associated with Duchenne muscular dystrophy. And it's going to be divided into two parts. The first part is going to be the introduction of the case, as well as some discussion about cardiac anatomy and some physiology. And then the second part will be more on the clinical presentation of cardiomyopathy, the different types of cardiomyopathy, and the treatment of cardiomyopathy. So I'm going to start off by presenting a case, and this is a case of a 44-year-old gentleman. He has a history of Becker muscular dystrophy, and he shows up in clinic because he's having difficulty breathing. He has gained approximately 15 pounds over the last month, and over the entire year, he's gained actually 30 pounds. Every time he lays down flat to go to sleep, he's becoming short of breath, and he's actually been having to sleep in a recliner recently because of the inability to sleep flat on his back. It's been getting progressively more difficult for him to walk upstairs. He lives in a 2-story home, and he needs to stop and catch his breath after each flight. So he understands what Becker muscular dystrophy is, that it affects the skeletal muscles of the body. But he's wondering why he's feeling so short of breath and why he's gaining this weight. So he comes into clinic and we perform a physical examination. And this is an exam of his neck veins. And the anatomy here is the external jugular vein. You can see distended from his lower jaw all the way down to his clavicle. The internal jugular vein, which is located underneath this line here, is also distended, but you can't really appreciate it in this picture because it's a pulsatile structure. Because his neck veins are distended, we're concerned that he's retaining fluid. And if you examine his lower extremities, his feet, you can see quite a bit of peripheral edema. This type of peripheral edema is called pitting edema, and the reason why is because if you press the foot, the dorsum, the top of the foot, with your finger, you can actually place a depression in the top of the foot. You can see a little dent located right here where somebody has pushed their thumb into the tissue and displaced some of the fluid in the foot. So he's got distended jugular veins and he has peripheral edema. His chest x-ray is shown here, and this is a classic case of pulmonary edema, fluid within the lung tissue. Normally, the lungs out here and here are usually completely black because they're filled with air and not water, and the x-ray goes right through them, so they appear black by radiography. But you can see that there's lots of fluid which causes the lungs to appear white because of the density of the water. So there's actually fluid in his lungs, which is certainly contributing to him feeling short of breath. So before I start talking about cardiomyopathy and congestive heart failure, I want to go over the anatomy of the heart and the blood vessels associated with the heart. And that's shown in this picture, which basically is the same picture that was seen, same anatomy that was seen in that chest x-ray that was seen previously. And I like to start with the right atrium here. And the right atrium is where all of the venous blood from the head, which comes through head and upper limbs, which comes from the superior vena cava, and it also the inferior vena cava, which is actually behind the diaphragm, which delivers all of the blood coming from the lower limbs and the trunk all into the right atrium. The blood then moves from the right atrium into the right ventricle, shown here, and then is then pumped out the pulmonary trunk to the lungs for oxygenation. It comes back from the lungs to the left atrium, which is located behind this picture, and ultimately into the left ventricle, which is shown here, and then is pumped out the aorta to the to the head and neck, and then also goes down behind the heart to the lower trunk and limbs to deliver oxygen to that part of the body. So looking at this in a little more detail, now you can see the inferior vena cava with blood flowing from the lower extremities up into the right atrium, and then also from the upper body, blood flowing from the superior vena cava down into the right atrium. They flow through the tricuspid valve, seen here, into the right ventricle, and then when the right ventricle contracts, it pumps the blood out the pulmonic valve into the pulmonary artery, which splits to go into the right lung and the left lung. It comes back from the lung through the pulmonary veins from the left side here and the right side here into the left atrium here. It goes through the mitral valve into the left ventricle, and then when the left ventricle contracts, it pushes the blood out the aortic valve into the aorta, which delivers blood to the head and upper limbs, and then down to the systemic circulation. In a little more detail, you can see how through the carotid arteries, the subclavian arteries, the blood flows up and branches into small capillaries to deliver oxygen to the tissue. And then once oxygen has been delivered and carbon dioxide has been acquired, then the blood returns back to the right atrium. Same thing happens with the lower extremities here. And then blood being pumped out the right ventricle goes to the left lung, and the right lung gets oxygenated and returns back into the left atrium. The pumping, the heart pumps because of electrical stimulation. The muscle cells are actually stimulated electrically, and what initiates the pumping is the depolarization of the sinoatrial node, which is shown here. Those are specialized cells that will depolarize spontaneously on their own. And they depolarize at a particular rate. And the rate that they depolarize determines the heart rate. So if these cells depolarize once every second, then that means that the heart rate is going to be 60 beats per minute. So once that area depolarizes, the sinoatrial node depolarizes, it causes the entire atrium, the upper part of the heart, to depolarize and pump the blood down through the atrioventricular valves into the ventricles, the bottom part of the heart. The electrical activity then depolarizes the atrioventricular node, and there's a small delay of a few milliseconds between the time the atria depolarizes and the atrioventricular node depolarizes, which causes the electrical activity to go down the center of the heart, the septum, down two branches of the His-Purkinje system. And that His-Purkinje system branches into very small branches to depolarize both of the ventricles, the lower part of the heart, at the same time. So there's a delay, actually, between the time at which the electrical activity of the heart is stimulated and there's a depolarization of the heart cells and the actual contractile response where the heart is actually pumping blood out. And that connection between those two episodes is called excitation-contraction coupling. So that the action potential occurs here, and there's a delay between the initiation of contractility of the heart and pumping of the blood out of the ventricle. So excitation-contraction coupling is the cardiac impulse starts at the sinoatrial node, the SA node. The action potential spreads throughout the whole right and left atrium. Then the impulse passes from the atria into the ventricles through that atrioventricular node where there's a little bit of a delay in electrical flow. And then the electrical progression is briefly, as I mentioned, briefly delayed, and then eventually the ventricles contract together. So this patient is displaying physical signs of congestive heart failure. He's got fluid retention, venous pressures are increased, he's got lower extremity edema, he has pulmonary edema on chest x-ray. And we know that Duchenne muscular dystrophy is a defect of the dystrophin gene in muscles. And that doesn't only include skeletal muscles, such as is displayed here, where you can see fibrosis of the muscles, but it also occurs in the heart. So let's look at this patient's heart. And the way we're going to look at the heart is through sonography. And when you do ultrasound of the heart, it's called echocardiography. And I'm illustrating what you can see with echocardiography here. These are two pictures. The first one is during systole, so when the heart is contracting. The second picture is during diastole, when the heart is relaxing. And the structures you see here are labeled. The probe, the echocardiographic probe, is at the top, and it's scanning downward into the tissue of the chest. And it's scanning back and forth very, very quickly. And the structures you can see are the right ventricle, shown here at the top, and then in between the right ventricle and the left ventricle here is the interventricular septum, shown here. There's also the mitral valve here and the papillary muscles that hold the mitral valve from everting. On the other side of the mitral valve is the left atrium, shown here, and the aortic valve up here. You can see that during systole, when the heart is actually contracting, the mitral valve is closed and the aortic valve is open. Whereas during diastole, in this picture, you can see that the mitral valve is now opened and the aortic valve is now closed. More detailed information about the anatomy is enumerated below these pictures. So let's look at a normal echocardiogram in real time. So you can see the heart contracting during systole and relaxing during diastole. You can see the mitral valve opening during diastole and the aortic valve opening during systole. An important thing to notice here is how well the left ventricle is contracting. The normal ejection fraction, which is the fraction of blood that's ejected from the heart with each beat, is approximately 60%. 60%. It's not physiologically possible to eject every single drop of blood from the heart and have an ejection fraction of 100%. 60% is about normal. So we performed an echocardiogram on this patient that came into clinic, and this is what it looked like. You can notice a few things here. First of all, you notice that the left ventricular cavity is very large, so this heart is dilated, and also that it's not contracting very well. In fact, you can see it's barely contracting. You can see the mitral valve opening. The mitral valve does open a bit, and the aortic valve is opening during systole, but the ejection fraction is much lower. The other thing that occurs when the ventricle dilates like that is it pulls the two mitral valve leaflets apart so that they don't close completely, and that allows blood to flow backwards, and that's called mitral regurgitation. That can be visualized using Doppler echocardiography. So Doppler is shown in this sort of triangular area where you can see that blue jet of blood going backwards from the orifice of the mitral valve. And that's considered a lot of mitral regurgitation. So not only is the heart not contracting very well and not pumping a lot of blood forward through the aortic valve, but a lot of the blood is actually going backwards through the mitral valve, decreasing the cardiac output, that is, how much blood is being delivered to the body. This stimulates a sympathetic response. So you have baroreceptors located in the aortic arch and located in the carotid arteries that can sense the amount of stretch of the blood vessel, in this case, the aorta or the carotid artery. And if the heart is not pumping out much blood, then there's less distension of that blood vessel, and that triggers a sympathetic response. And that goes from the blood vessel up to the brain, actually in the medulla. And it initiates a sympathetic response, activates adrenergic response to a low blood pressure and low cardiac output. Now, the normally there's a sympathetic limb and there's a parasympathetic limb, and those two nervous systems work together to sort of fine-tune the amount of activation, sympathetic activation, and parasympathetic activation. So in this case, the lack of distension of the blood vessels triggers the baroreceptors to stimulate the cardioaccelerator center in the medulla of the brain stem. And that initiates signaling down the sympathetic nerves that innervate the heart. And those nerves release something called norepinephrine. And norepinephrine stimulates the heart to contract harder and beat faster. And that's appropriate in response to a decreased cardiac output caused by this new cardiomyopathy. It also inhibits stimulation through the vagus nerve, which actually tends to slow the heart rate down. So the ultimate effect is increased heart rate, increased contractility, which is a good adaptive response. The way norepinephrine triggers increased contractility is depicted here molecularly. And norepinephrine activates beta-1 adrenergic receptors at the cell surface of the cardiomyocyte, which is the cell that makes up the heart muscle. And stimulation of beta-1 adrenergic receptors is linked through a G protein that causes activation of adenylate cyclase. And as you may know, adenylate cyclase converts ADP into cyclic AMP, and cyclic AMP activates inactive protein kinases into active protein kinases. And it's these active protein kinases that then alter, usually by phosphorylation, different proteins to cause the response to the adrenergic stimulation. The first thing is activated protein kinases will phosphorylate sodium channels in the cell membrane. And those sodium channels, in this case, are specific sodium channels that are found only in the pacemaker cells. And when you increase conductance of sodium down these channels because of phosphorylation by the protein kinase, that increases the flow of sodium, which pushes the sinoatrial node closer to depolarization quicker. So instead of beating once every 1 second and having a heart rate of 60 beats per minute, it's beating once every half a second, and your heart rate's 120 beats per minute. The second thing that activated protein kinases do to increase contractility is they open up they phosphorylate voltage-gated calcium channels, shown here, that increase calcium conductance. And as you're probably aware, calcium is very important for muscle contractility, and as the calcium flows in, it activates the sarcoplasmic reticulum, and this is a calcium-dependent calcium release. So more calcium is released, which then interacts with troponin to increase actin and myosin cross-bridging and increase contractility. Ultimately, increasing contractile force and velocity. The effect of sympathetic stimulation also increases stroke volume. So instead of the heart having an ejection fraction of 60%, it'll actually increase the stroke volume and where you'll be ejecting actually more volume of blood out with every beat. And this illustrates that situation. Normally, normal stroke volume at the end diastolic volume is approximately 135 milliliters. When the heart contracts, it ejects approximately 70 milliliters of blood. And so that your end systolic volume, in other words, what's left in the heart after the heart has contracted, is approximately 65 milliliters. With sympathetic stimulation, that is activation of beta-1 receptors on myocytes by norepinephrine, causing that cascade of events that was described in the previous slide, increases contractility so that the stroke volume increases from 70 milliliters up to 100 milliliters, so that the end systolic volume, instead of being 65 milliliters, is now 35 milliliters. So it's a way of increasing the cardiac output of the heart by using this adrenergic stimulation. Furthermore, because of the increased cardiac output, there's increased venous return. So all that blood that's pumped out is coming back to the heart, which fills the heart even more. So the end diastolic volume actually increases. And it can increase from 135 milliliters up to 175 milliliters. Now, the addition of the increased end diastolic volume plus the decreased end systolic volume, the stroke volume goes up from 100 to 140. So just by sympathetic stimulation, you can actually double the amount of blood that you're delivering to the body with every beat of the heart. The stretching of the left ventricle, the myocardium, is important, and that in that you're stretching the sarcomere length. And there's a phenomenon, because of the way that the actin and myosin are oriented, that you can actually increase the tension of the muscle. And I'm showing, this is a graph showing the relative tension on one axis and sarcomere length on the other axis. And when the muscle is completely contracted, you're unable to generate a lot of tension. But as the muscle stretches, you actually increase the number of actin and myosin bridges that can interact with each other, and they're able to generate more force. As you keep stretching it, you have, in this case, maximal actin and myosin interaction here. And as you stretch more, you still have all the actin and myosin interacting with each other. But then once you stretch the sarcomere farther, you start to lose this actin and myosin interaction, and you're unable to generate as much relative tension as you did when all of the actin and myosin filaments were interacting. And eventually, when you stretch the heart out enough, you're able to generate very small amount of force. So you can see that, as thinking back to that echocardiogram of the patient where the left ventricle is very dilated and stretched, what happens is ultimately you start getting to this limb of the length-tension relationship, and it becomes more and more difficult to actually generate force to pump blood out of the body, out of the heart. And that's illustrated here using, and this is an illustration of the Frank-Starling Curve. And what this shows is stroke volume here. So this is the amount in milliliters that's being pumped out of the blood. And here is the end diastolic volume. So the volume within the left ventricle before contraction. And as you stretch the heart and you go from volume A to volume B, so increase the end diastolic volume, you increase the stroke volume from A to B, just like was seen in the previous slide. Eventually, and this occurs up until the point where you start stretching the sarcomere length so much that you start losing actin and myosin interactions. And at that point, which is considered the optimum length, then tension or stroke volume actually starts to drop off beyond that point. And it's really at that point that people who are developing a cardiomyopathy or congestive heart failure actually start becoming very symptomatic, because now they're unable to deliver enough blood to their body, which is essentially the definition of congestive heart failure. So I'm going to stop there. That's the end of the first part of the lecture. We're going to start the second part, which will be more looking at the effects of the causes of edema and the treatment of Duchenne muscular dystrophy-induced cardiomyopathy.